Okay. Okay. So, Rachel, what do you see?
See a lot of stratum corneum.
A lot of stratum corneum, exactly. You know, given that the epidermis itself is this tiny little layer there, so massive corneum. What might that translate to?
Like maybe aqueous surface or a lot of scale, like ichthyosis vulgaris.
Yeah, so it's certainly not a. It's certainly not a confluent, compact hyperkeratosis like you would get on a normal palmar sole.
Yeah.
And normal palmar sole will have a granular layer in proportion to the corneum, and also have a stratum lucidum, none of which you see here. It's kind of in whorls, which is abnormal. Scale is parakeratotic. Adherent hyperkeratosis is orthokeratotic. So this would probably be adherent, very, very thick. And you can even see areas where it's fissured. So it'd be thick fissured plates, this is pretty typical for what you see with a harlequin fetus. So just massive hyperkeratosis, and those the whorled keratin pattern is pretty typical. Okay. Sarah, what do you see?
So it looks like there's acantholysis.
Just acantholysis or also dyskeratosis?
There's also dyskeratosis in there.
And are all the rings red, or are there clear rings?
There's also clear rings.
They're clear rings. So if you see blue rings, clear rings, red rings, what condition is it not?
It's not going to be like Darier's.
It's not going to be Haley, correct. So Haley is the one that only makes red rings.
Okay.
Right? So Haley only knows how to make red rings. All the others can make red, clear, blue.
Okay.
Haley only makes red. That's the only type it knows how to make. Okay, so in this case, you have clefting. What are these round bodies, if you were French?
They're corons.
Corons, which Derier thought was a fungal organism, and it was actually Dr. White in the United States who got it right, which is why it's sometimes Derier-White disease. Derier described it first, but he got it wrong, thinking he had described a fungal infection, thinking those were spores. So you often have suprabasilar clefting. It can form villi. This is, villus formation here. The corons are the round ones, and they can have red ring, blue ring, clear ring, whereas Haley only ever does red. And then if you see flat ones like this, that's a grain, because it resembles a grain. Okay, so that's... Okay. So what do you see?
So it appears to be some prominent acanthosis with very stringy reedy.
Very long, stringy reedy.
Makes me think of lipoproteinosis with that, the hyperkeratosis as well.
So lightboard parotenosis, the key would be the pink hyaline rings in the papillodermis and around adnexal structures and blood vessels. Don't really see any hyaline rings here. Is the epidermis intact or is it acantholytic?
It looks like it's acantholytic.
And is it acantholytic or is it also dyskeratotic?
Also dyskeratotic.
So you have acantholytic dyskeratosis. And are they all red or do you have some clear ones? Like right at the point of the arrow.
That looks pretty clear.
That's pretty clear, right? So what condition is it not?
Not Haley.
Not Haley, because that only makes red ones. So this is something with corons and very long elongation of the redi with cleft formation. What could it be?
Possibly berries.
Yeah, this is a nodular Dariés. But it's a little big for Grovers. You know, Grovers tend to be very small foci. If it were a solitary lesion, rule out squame, then it's warty dyskeratoma. So a warty D is a solitary lesion of acantholytic dyskeratosis that is either crateriform or resembles an expanded follicle. Other things that are localized include acantholytic dyskeratomas, which are stuck on and look kind of like sebs, and the vulvocrural acantholytic dyskeratosis, which is scrotum and usually vulva in women. So they are keratotic lesions of the vulva in women, thought to be venereal wart cancer, not sure what it is. They get biopsied, and it looks like Dariés, but they don't have Dariés elsewhere. It's localized. It's 99% women. Rarely you'll see it on a scrotum. It's almost always vulvar.
Does syphilis look like that?
Syphilis gives you elongation of redi in many cases, but does not give you acantholytic dyskeratosis. Okay.
Alright, so it looks a little bit papillomatous in the middle, but that might just be acanthosis or acantholysis.
So there's definitely acanthosis, and there's also acantholysis. And is the acantholysis restricted to the basal layer like the Dariés, or does this one go full thickness like a dilapidated brick wall?
This is more Haley-like.
And anything else that might be a clue to Haley?
The red.
So all the rings are red. There's no ring any other color. So that's good for Haley. Who described it first?
Probably
Haley. Yeah. Okay. Okay.
Punch from here looks kind of effaced, a little bit boring. The dermis, not too much going on. Looks like there is a granular layer, maybe a little bit attenuated.
Yeah, there's certainly a lot of corneum, right?
Mm-hmm.
If you thought your granular were attenuated, then you'd be thinking
Probably like a ichthyosis vulgaris or something more
yeah.
mild. In
It's
the face.
unusual for ichthyosis vulgaris to be lamellar, though. To have a lamellar stratum corneum. So what if we were to say that that's a preserved granular layer and you have a lamellar hyperkeratosis? Looking at your epidermis, is this more a retention hyperkeratosis or a hyperproliferative hyperkeratosis?
I think the latter.
hyperproliferative, usually you have proliferation of the epithelium. In a retention, your epithelium looks normal, boring, flat, thin, with a lot of... It's not always the second, sorry. Okay, so in this one, probably more like a retention hyperkeratosis. I didn't mean it that way, it just came out that way. So retention hyperkeratosis, being that your corneum's pretty thin and boring, or I'm sorry, your epithelium is pretty thin and boring. It's probably a retention hyperkeratosis. What if this is a guy and he says he looks pretty normal in the summer, but he looks horrible in the winter? Which one affects guys and is distinctly seasonal? The big hint is it affects guys. Excellent. So X-linked is, you are the best dermatologist in the world if they come to see you in the spring, because they're going to be clear all summer. You are the worst dermatologist in the world if they come to see you in the fall, because they're just getting bad for the year, right? And for a lot of them, moving to a different climate is when they present. So they grew up in South Florida. Their skin was never that bad. Now they've moved to Toledo, and their skin is horrible in the winter, right? Very sensitive to the change. How did they come into the world?
So they can come in kind of dirty scale, like early on.
But usually the skin is reasonably normal at birth. I was thinking cesarean.
Oh.
Because the X-linked ichthyosis steroid sulfatase is required to initiate labor. So you see the guy with kind of a dirty looking hyperkeratosis, and you elicit a history of dramatic seasonal variants, and you say, by the way, were you a cesarean birth? Why, yes, I was. How did you know that? Because you have X-linked ichthyosis, and the enzyme not only is required to cleave the steroid sulfate that produces adherence of the corneum, so it is required for shedding of the corneum, but it also is what initiates labor. And what's the other name for steroid sulfatase? Aryl sulfatase C. You could see it under either name because they're both valid names for it. Okay. Is this more of a lamellar or more of a very, very compact red?
It's very compact red.
So this one's more compact red. Sorry, the usual second one.
And granular layers.
And granular layers deficient, so this is probably, that's more like ichthyosis vulgaris. The last one, with the very unimpressive corneum, but more lamellar, very thick, is more characteristic of X-linked. IV tends to be really red with no visible space, no visible lamellation between them. Distinctly absent granular. Your epidermis is not particularly hyperplastic because, again, it's a retention hyperkeratosis. In X-linked, it's lack of steroid sulfatase, which is required to cleave the steroid sulfate and allow the cornocytes to come apart. And in ichthyosis vulgaris, it's lack of a granular. The granular layer, the keratohyalin, absorbs water every time you take a shower or bath, and then it dries out. Absorbs water, dries out. That pries the corneocytes apart. That repeated expansion and contraction pries the cornocytes apart and allows them to shed. Without that, you have a retention hyperkeratosis. And so what would you say is normally deficient in in Ichthyosis vulgaris.
Flared?
Yeah, filaggrin, which is major protein in keratohyalin granules. So it's filaggrin mutations. Okay, Derek, what do you see here?
There is some acanthosis, acantholysis.
So acantholysis, you can say acantholysis, but most people say acantholysis. I don't think either one's
I think
wrong.
I say both sometimes.
It's just
Depends where my
it's
tongue
just
is.
what most of the other kids say is acantholysis. There's definitely an impetiginized crust. You can see neutrophils. You can see tons of staphylococci. So impetiginized crust, acanthosis with acantholysis, and then tell me about the rings around the nuclei.
Looks like they're. I think there's both colors.
There
Maybe
is
just-
one little cell acting out there. The rest of them are red.
Red
Clinically, this was Haley-Haley. That one cell is the exception that proves the rule. It is very, very rare to see any clear or blue rings in Haley-Haley. In fact, this may be the first example where I could take a picture and say, there, you got one clear one right there. Your predominant pattern is they're distinctly red rings
Okay.
around
So,
the nuclei. So clinically, that was Haley-Haley.
Similar pattern here, a lot of acantholysis and dyskeratosis, seeing some distinctly blue and clear rings.
Distinctly blue and clear ones.
So I was thinking of like a worry dyskeratoma, it does look kind of isolated, or Darier's, or
Yeah, or because
Grovers.
it's very small, Grovers.
Yeah.
What if I told you this was keratotic lesions of the groin and crural area in a female?
Vulvar dyskeratosis.
Yeah,
thing.
vulvar dyskeratosis, vulvar crural, it goes under numerous names. So we have here. Okay, how about this?
It's in the derms, so there's diffused deposit of some nephroprotein.
So that's the dermis down there. So that's huge corneum.
Oh,
There we go.
I see. So this is very hyperkeratosis with granule layer disappeared. So it's Ichthyosis vulgaris.
So there is massive hyperkeratosis with granular layer gone. It's a little thick for Ichthyosis vulgaris. I mean, this is very, very thick. Anything helpful at the edge that could explain what's going on here?
So there is some dyskeratosis.
Dyskeratotic cells, and they form a wedge with a column of perikeratosis.
So maybe it's a viral stage of the pigmented incontinence.
So incontinentia pigmenti verruca stage, you'd have those dyskeratotic cells throughout. Still's disease can have them scattered throughout. Usually not this massive hyperkeratosis, though. But what else would give you a wedge of dyskeratosis like that? Anyone? Poro. And remember, center of poro can look like anything. Center of poro can have hyperkeratosis, can be atrophic, can be lichenoid, psoriasiform. So always look at the edges for the cornoid lamella. So porokeratosis, that was a tough one. You did fine.
Yeah. I know.
Okay. How about this one?
So it looks like we got some acantholysis.
Acantholysis.
Looks like it's mostly making red.
Looks like mainly making red.
I'd say more Haley.
So you might want clinical information on the patient. Unusual to get villi like that in Haley. So you'd want a little clinical, but this was apparently Haley, and the red rings certainly go with that. Okay, Rob.
So, looks like you have some almost orthohyperkeratosis, but it's kind of flaking away in some areas, and then
Orthokeratosis, focal parakeratosis. It alternates like an inflammatory linear verrucous epidermal nevus. So we got our diagnosis, right?
looks like a poro.
Yes, exactly. And center of poro can look like anything. In this case, center of poro looks like Ilvin.
Yeah.
So, always look for your cornoid lamella on the side because center of poro can look like anything at all.
So if you don't get the side of the biopsy,
Okay. Brett, are you passing or playing?
Alright, so very compact, thick.
Very compact, thick, very red.
Yep. So it's like an ichthyosis vulgaris.
More likely hyperproliferative or
Well, it is a little
retention.
lamellar, but it's so pink.
Yeah, so pink. And is your epithelium particularly thick?
No.
No, that's one of the hints in like a lamellar ichthyosis is that you have epidermal hyperplasia as well because it's a hyperproliferative ichthyosis. So lamellar EHK are hyperproliferative, whereas X-linked IV tend to be just retention. And then, how about this on the side?
Looks like a plugged
Follicle.
follicle.
So what do you get associated with ichthyosis vulgaris?
KP.
KP. Yeah, because they're often atopic and they get keratosis pilaris, so that's a very, very common association. There is a lot of Haley and Darius in this box.
We had a different box the other day we were going through that had a lot of not.
A lot of not.
Yeah.
Okay, let's grab.
There's another one
maybe
here that
switching
has
boxes.
best written on it.
Okay, that's probably the one.
What does it have written on?
BEST.
So anytime you have a box that has best written on it, it just means that I went through and there was an assortment, made sure that everything was represented in there, and then gradually as people use the boxes and put them back in different boxes, then it's no longer the best.
We do like to play games.
It's cruel. Okay. So let's try some different things here.
You should probably write worst on the other one.
Great if you want to see lots of Darius versus Haley. Okay, how about this?
so it looks like PXE.
Looks like Pseudoxanthoma elasticum, which, those little fragmented calcified elastic fibers in Singapore, they refer to it as chicken floss. Which go online and look up chicken floss. It's like they use it in place of salt. It's little like shredded particulate salty chicken that they put on everything from eggs to rice to vegetables. So chicken floss.
You make that thing?
It's very tasty.
Homemade meat floss.
There you go.
It's like mint barbecue, kind of.
When they manufacture it, if they're doing it right, it ends up the consistency of PXE. That's how they do quality control. Okay.
So the cornea looks pretty normal basket weave. It's a granular layer. Epidermis looks pretty normal. There's not much acanthosis.
So you've got, at scan, it doesn't look that much different from normal, right? So there are mnemonics that can help with that. There's the I vacuum dog pus mnemonic. It's in the back of your book, which is for normal, at first glance it looks pretty normal to you. You're having trouble. The IV ichthyosis vulgaris. So do you think this is ichthyosis vulgaris?
No, I don't.
No, your corneum's blue, not red, and it's basket weave, not compact, right? So it's probably not ichthyosis vulgaris. The Argyria is another one. If you look down around the eccrine coil, look for little black dots. Not there. We're just going to get to one of the U's is Urticaria pigmentosa. See these little granular cells all through here? Kind of blue granular cells. So when it's just a little bit hypercellular in the papillary dermis, it would look almost like fibroblasts. They're spindled. Like big chunky fibroblasts have little blue granules in them. That's typical for what type?
The TMAP type.
TMAP, telangiectasia macularis eruptiva perstans, which kind of says it all. There's telangiectasia, there's macular hyperpigmentation, it erupts with urticaria, and does it go away? No, it's perstans, right? So that's a very TMAP-like appearance. Scan doesn't jump out at you until you see this area here. So what's going on there?
It looks like a corons, or not, dyskeratosis with some dead reds.
What are these granules? And why are some of them blue and some of them red? And then there are little vacuoles in there. So what would give you vacuoles in a granular layer with both blue and red granules?
Epidermolytic ichthyosis.
Epidermolytic ichthyosis, where it would be the whole epidermis, or if it's very focal, it's just isolated EHK, epidermolytic hyperkeratosis, which is a common incidental finding, especially associated with atypical nevi. That's really, really common. Okay, so Caitlin, what do you see here?
There's a big horn.
Big horn.
Let's see. Really, are a little bit elongated. Oh, we got another one. Poro.
So poro, another verrucous poro. A lot of the verrucous poro are in this box because it can mimic ichthyosis, it can mimic, various genoderms. Okay, Brian, how about this one?
This is a large aggregate of mast cells.
It is a large aggregate of mast cells.
So this would put me into a solitary mastocytoma.
Yeah,
versus
looks more like a solitary mastocytoma. Mast cells look like fried eggs, not one I would want to eat because the yolk is black. Right? But so-called fried egg appearance, and when they tend to be in sheets like that, the nuclei are very evenly spaced. So as opposed to an inflammatory infiltrate, where the nuclei vary in their spacing, mast cells, because the cytoplasm all tends to be about the same size, you have a polka dot pattern where they're all evenly spaced apart. And that's typical at scan for a mastocytoma. Well done.
Just put some chicken sauce on the eggs.
Actually, it's remarkably good.
Chicken floss.
Pork floss is good too.
We call that
barb will be
Okay.
So let's do.
It's kind of an endophytic lesion, slightly. There's some acantholysis and some dyskeratosis. So thinking of warty dyskeratoma, perhaps.
Yeah, so if it's a solitary lesion, warty dyskeratoma, it's a Haley pattern, right?
No, it's got clear rings and it's
Definitely has clear and blue rings. Sorry, I got that wrong. So it's a good thing you set me straight. But you see suprabasilar acantholysis, you see villi, you see red, clear, and blue rings, which means it's not Haley. If it's a solitary lesion, this would be good for a warty dyskeratoma, but this was by history a patient with Darier's. Looks the same. It's just acantholytic dyskeratosis with red, blue, and clear rings.
A very thick stratum corneum.
Very thick stratum corneum.
Some acanthosis. Looks like some epidermal lysis. So EHK.
So yes. You said hyperkeratosis and epidermolysis, so you flip it around and you got epidermolytic hyperkeratosis. Now it's on palm. You can see normal palmar corneum here. So what would this hyperkeratotic palmar lesion with EHK be? There is an epidermolytic variant of keratosis palmaris et plantaris.
Okay.
So this person would not have ichthyosis all over, but could have just isolated inherited KPP with EHK.
Okay.
How we're doing here. Okay.
This is a pretty endophytic lesion, I feel like there. There's some dyskeratosis as well and acantholysis. So they like go up into the corneum. And some of the granules almost look like EHK a little bit too, I'm not sure. But it does look like maybe a warty dyskeratoma or something along those lines.
Yeah. So one of the clues to EHK is you always have a very compact corneum.
Okay.
This one's more basket weave, and you can see some of the dyskeratotic chorons spitting out. There are lots of chorons present. If this were a solitary lesion, it could be a warty dyskeratoma. Remember, those are quite common on the alveolar ridge, so they present as crateriform things on the alveolar ridge, thought to be squamous cell carcinoma. And then on biopsy, it looks like Darier's. That's a warty D on the alveolar ridge. That's one of the, we tend to see the cutaneous ones. The dentists see the oral ones, which in some studies are the more common. If the patient has V nicking and red and white streaks in their nails,
Darier's.
more likely Darier's. Let's get
So there is a disorder in the epidermis with many very red numbers of dyskeratosis, and this is the verruciform stage of pigment incontinence.
Very good. So pass that easy button over. So this one is the verruca stage of IP.
That was easy.
So you have, first off, you have very delicate, pretty dark red staining collagen with a lot of fibroblasts. That's baby skin. So kid skin or baby skin. And lots of dead reds, and those dead reds can move up into the corneum as little whorls sometimes. We're not seeing many of them yet. That's the verruca stage of IP. Other things that look very similar to that, subungual keratoacanthoma looks very similar to IP with all the dyskeratotic cells, and Still's disease. The later stage of Still's looks just like IP with the dyskeratotic dead reds going up to a starry night pattern of whorls in the stratum corneum. So if you're someone with unexplained fevers and a ferritin through the roof, you got Still's. If you've got a solitary subungual painful hyperkeratotic lesion, you have a subungual KA unless it's the subungual hyperkeratotic lesion of IP. And there's some suggestion that what we call subungual KAs are isolated segmental mutations for IP in the nail bed. So subungual keratoacanthoma, at least a lot of them may be isolated linear lesions of incontinentia pigmenti in the nail bed. And they can be horribly painful. Howard Pride shows pictures of a very stubby individual who finally had the orthopedic surgeons amputate distal because they could do nothing to control the pain of the subungual lesions. That's pretty dramatic, but the individual just could not live the way they were. So first off, what do you think the age of the patient is?
Pretty young.
Pretty young. How do you know that?
The delicate kind of really pink staining color.
Yeah, so it's a very red staining, very small collagen bundles. So it's probably a kid. And then this kid has lichen planus.
I don't think those are limbs.
Why? What makes you think they're not limbs?
They look too uniform to me.
Very evenly spaced in a polka dot pattern?
Mm-hmm.
What could do that in a child?
Mast cells?
Yes. So, mastocytoma, very good. Get those guys back in.
Well, we have a lot of compact orthohyperkeratosis.
And where do you think you are?
Acrally.
Yeah, probably volar. Acral just means distal.
Right.
Volar means palmar
yeah.
sole.
Definitely volar.
And, this could be, it's a little thick even for a palm, right? So you want to know, is this diffuse or is it punctate?
It's hard to tell just because it's
It is hard to tell from the biopsy because they just punched out an area.
Right.
So if it's diffuse on the palms and soles and does not extend over the margin, the proximal margin of the palm.
This is more materials.
Yeah, KPP. And what's the most common one that just stays with no transgredients? No, Maldomolita definitely has transgredients. And Papillon Lefebvre also has that and has bad teeth, periodontal disease. This one, the Una, people say Una Thost. He was German, so is Una Toast. Like you spread jam on your toast. But Una Toast or Una Thost, whichever, is your most common diffuse KPP with no transgredients.
So you definitely have some dyskeratosis within the dermis as
Dyskeratosis.
well as a lot of EOs with the skin.
EOs.
Maybe it's about one of the early stages of IP.
Yeah. So this is vesicular IP just becoming verrucous. And you see where the dyskeratotic cells move up into the corneum as those little whorls there? That's what you can get in stills. But stills would never give you the spongiosis with the eosinophils. And the clinical, of course, would be very different.
Looks like we're mostly dealing with something in the dermis. Things like the dermis looks fairly normal.
Okay.
And I don't think these are. I don't think that they're like regular lymphocytes.
They look kind of granular, right?
Yeah, so are they mast cells?
They are mast cells, and they're fairly evenly spaced apart, so this is probably, yeah, solitary mastocytoma. Seen a whole lot at scan?
Not a whole lot.
Okay, so you can run through your eye vacuum dog pus differential. The one that happens to be in this chapter where you have these spindle cells that are a little chunky, a little granular, and would happen to stain with a leader stain would be...
Spindle mast cells, so it's like TMAP again.
Yeah, so TMAP, telangiectasia macularis eruptiva perstans.
Oh, it's under that period pigmentosa, yeah. Sort of under that umbrella.
Okay. But TMAP is not urticaria pigmentosa, right?
TMAP is, it's mastocytosis,
Right.
but UP is multiple mastocytomas in a kid.
Okay.
They about 10%, 10 to 20% have lytic bone lesions, but you don't look for them because they self-resolve and you do nothing to treat them unless they're symptomatic. So unless there's signs or symptoms, you don't look. Because if you look, you'll find lytic bone lesions in 10 to 20%, and then the parents say, "What do we do?" And you say, "Nothing." So why did you look?
So at this scan, it kind of looks like chicken floss.
Kind of looks like chicken floss. So this is
PXE.
PXE, except that this patient has no plucked chicken skin look on their sides of their neck. They have no angioid streaks in their retina. It's a 65-year-old black woman who's had lots and lots of kids, and this is on her abdomen.
The periumbilical.
So it's either called periumbilical perforating PXE, because it looks like PXE. It's kind of a misnomer. So the other name for it is perforating calcific elastosis. What it represents is just calcified stria. So stria, it's usually, the classic description is a multiparous black female. And it's calcified stria, periumbilical, and it looks like PXE histologically. But they do not have any other stigmata of PXE.
Let's see. Just a little bit of a horn. Dermis might be a little bit acanthotic, but it looks like there's an infiltrate beneath. But yeah, and there's it again.
So this is
Coro.
Chorokeratosis cornoid lamella.
Very good. Let's see what else we should know here.
Theme song.
To get a few things that are different here.
Can we put that in the worst box?
We could. Or my personal nightmare box. Did you, with with one of the fellows, did you go through the
Yeah.
the unknowns?
Yes.
Okay, so there you have sort of one of everything.
Yeah. Yeah.
And then you got to go through some boxes on your own to make sure you reinforce.
Pretty boring.
So pretty boring.
Possibly Ichthyosis vulgaris.
Possibly Ichthyosis vulgaris. Portions of it look compact and red like IV. Some are a little more lamellar. Any things you could do clinically to differentiate types of ichthyosis? So first off, is this likely to be EHK?
Does not look like it.
No, because there's no EHK, right? Is it likely to be lamellar ichthyosis?
The horn's not big enough.
No, that usually has hypergranulosis and and hyperplasia of the epidermis. So this is more likely a retention hyperkeratosis. What are your two major forms of ichthyosis that are retention?
Yeah, that X-linked would be, and then...
So X-linked and IV. And then which one tends to involve the flexures?
That's going to be more X-linked.
X-linked is more likely to involve with dirty scale, whereas XP distinctly spares flexures. And any other questions you could ask the patient that would help distinguish?
How did you come into this world?
So cesarean birth goes with X-linked. And also, do you have a lot of seasonal variation with your skin? Because all ichthyosis can have some degree of seasonal variation, just humidity, they do better. But X-linked, it's usually really dramatic. Like, I look normal in the summer and I look horrible in the winter. Let's see, we've got time for just a few more here.
This nice like vascularization, like a shotgun of the granule layer, like a EHK.
Yeah. So compact hyperkeratosis, the thickened granular, all shot full of holes, and if you look higher, you'll see irregular both red and blue granules. And is bullous congenital ichthyosiform erythroderma, which is also called EHK. I'm going through these. Try to pull a variety out of here. See if there are any things we haven't hit yet. Okay. In the meantime,
A lot of sebaceous activity.
lots of sebaceous. May just be something like a nose that has a lot of sebaceous glands.
There's an acanthosis.
Oops, sorry. So, acantholysis and dyskeratosis, clefting, formation of villi.
Warty dyskeratoma.
So, warty D if it's solitary, if there are nail changes and it's V of the chest, polydaries, Grover's, vulvocrural dyskeratosis. You need the clinical to know what it is.
In the acrokeratosis and Darius, do you see any acantholysis, or is this more of a warty?
You can occasionally. So, acrokeratosis verruciformis will show occasional corons. Other times it just looks kind of like a wart without a whole lot of hypergranulosis. Certainly no corlocytosis.
Another acantholytic type process going on here. think I'm seeing mostly red. It's kind of going all the way, well, part of the way through at least.
So this brick wall is only partially bad.
Half dilapidated.
Yeah.
Probably heavy.
So that is a brick wall that might just make it.
Yeah,
Okay.
Just called
Later.
Yep.
Oh,
It's okay.
sorry. It's Paroma. With the.
So you're thinking the right thing and said the wrong word. Porokeratosis.
Prokeratosis.
Porokeratosis. Not Poroma acrospiroma, but porokeratosis with a cornoid lamella. Correct. Very good. No, that it is okay. And the terms run together.
So it looks like there's like a compact horn. Is that a portal right there?
It is. Porokeratosis again. Anything good in there?
There's one that wasn't in the chapter, but it may be interesting.
Okay.
Nothing else has been.
Okay. So we'll do a few more here.
Looks like PXE.
Looks like PXE. You didn't say chicken floss, but I'll accept it. Anyway. I actually took a good picture of chicken floss on my eggs in the morning that I'll send around.
Looks like there's some dyskeratosis.
Yeah. So kind of a glassy hyperkeratosis, or I'm sorry, glassy acanthosis, reminiscent of keratoacanthoma with lots and lots of dyskeratotic cells. So what could that be?
I remember hearing this one, but I forget.
So, anyone? So it could be verruca stage IP, subungual keratoacanthoma looks identical, possibly because subungual keratoacanthoma, some of them share the same mutation probably as incontinente pigmenti. Okay. Let's see what we got here. Ah! Looking for one of these.
Oh boy.
Okay. So whose turn are we?
This kind of has that vertical streaking.
Vertical streaking.
Hyaline lipoid protein.
Yeah, so this is the hyaline material, vertical streaking around vessels, sometimes very prominent around eccrine ducts.
And they talk like this because it gets into their vocal cords as well. And they have the string of pearls that change on their eyelids.
So that's all lipoid proteinosis. Okay. If that helps you remember it. Okay, I think we're done.
Thank you. Thanks, Dr. Austin.